Okay, let's unpack this. If you've ever wrestled with losing weight and keeping it off, you know how profoundly challenging that can be.
It really is.
It's more than just willpower, right?
Mhm.
Our bodies have these complex systems, sort of designed, in part, to resist significant weight loss.
That's a crucial point. For so long, the tools available for sustained, really impactful weight management, beyond diet and exercise, they felt limited.
Totally. But in recent years, there's been this incredible buzz, like a real shift in the conversation around new medical options that seem to be, well, changing the game for a lot of people.
That struggle is incredibly common, yeah. And understanding obesity as a chronic disease with these underlying biological factors, that's key. Finding effective long-term strategies that work with those biological realities rather than constantly fighting against them, that's a major goal in medicine now.
Which brings us directly to today's deep dive. We are going to try and cut through some of the noise and take a really close, evidence-based look at one medication that's gotten a ton of attention, semaglutide. Specifically, we're diving deep into its long-term efficacy and safety for weight loss in a particular group of people, adults who are overweight or obese and, crucially, do not have diabetes.
Yes, that non-diabetic distinction is really vital here. While semaglutide was initially used for type 2 diabetes, its approval, used specifically for chronic weight management in people without diabetes, represents a pretty significant development. It addresses a major public health challenge.
Right. And to get the true picture, we're not just relying on single studies, which, can sometimes be limited or maybe even a bit misleading.
Definitely.
For this deep dive, we've stacked up the evidence. We're focusing on what's considered some of the highest quality research available, 2 detailed systematic reviews and meta-analyses. And these looked at multiple randomized controlled trials.
And maybe we should just quickly explain what that means. Think of a systematic review as researchers doing the really painstaking work of finding all the high-quality studies on a specific topic, like this one, semaglutide for weight loss in non-diabetics. They gather all the data, they rigorously check the quality of each study, and then in what's called a meta-analysis, they statistically combine the results from all those studies. It's almost like creating one giant super study.
Ah, okay. Pooling all the data.
Exactly. It pools data from potentially thousands of participants, which gives us a much clearer, more reliable signal about the overall effect and the safety profile than any single trial could possibly provide on its own. It really helps minimize the impact of, say, chance findings or biases that might creep into individual studies.
Got it. So it's like getting that view from 30,000 feet, but it's built on really detailed groundwork from multiple studies.
Precisely.
So our mission today is to unpack what these comprehensive analyses actually found. We want to pull out the most important nuggets of knowledge for you. How well does semaglutide really work for sustained weight loss in this population? What does it do to important health markers beyond just the scale? And what does the safety picture truly look like based on all this combined evidence?
Yeah, the goal is to give you a well-informed perspective and quickly helping you understand the science that's actually behind the headlines you might be seeing.
Exactly. It's about understanding the size of the potential benefit and the nature of the potential risks as seen across the most robust data we have right now.
Let's get into it.
Precisely. So let's unpack this. All right, jumping in, let's start with the basics. What is semaglutide at its core, and how does it actually relate to weight?
Okay, so semaglutide belongs to a class of medications called GLP-1 receptor agonists. You might see it written as GLP-1RAs.
GLP-1RAs, right?
And this class of drugs, they basically mimic the action of a natural hormone our bodies make, called glucagon-like peptide 1, or GLP-1. Our bodies release this hormone after we eat.
Ah, okay. So it's based on something our body already does.
Exactly. And GLP-1 has several important jobs, mostly related to regulating blood sugar and, crucially for this discussion, influencing appetite.
And as you mentioned earlier, its history is really rooted in treating type 2 diabetes.
Yes, absolutely. GLP-1RAs were first developed and are still very widely used for managing type 2 diabetes. In that context, they help lower blood sugar mainly by stimulating insulin secretion, but only when blood sugar levels are high.
Okay, so it's smart in that way.
And also by suppressing the release of glucagon, which is a hormone that raises blood sugar. One of the sources we looked at, Moiz et al., mentions the early SUSTAIN trials, for instance, which showed these blood sugar control benefits in people with diabetes.
But then something kind of unexpected happened in those diabetes trials, didn't it? Researchers started noticing pretty significant weight loss almost as a side effect.
That's exactly right. The weight loss they observed in patients with diabetes who were using these medications was often quite substantial, and it was consistent across studies. This really sparked the idea that, hey, maybe these drugs could be powerful tools specifically for weight management, even in people without diabetes, where weight loss itself is the main goal.
So the weight loss isn't just a downstream effect of better blood sugar control then. How do they think GLP-1 RAs like semaglutide actually work for weight loss itself?
Yeah, that's a great question. The sources really elaborate on this. While they do have those metabolic effects we mentioned, the main drivers of weight loss seem to be related more to the brain and the gut.
Interesting. How so?
Well, GLP-1 receptors are found in areas of the brain that control appetite and satiety feelings of fullness, particularly in a region called the hypothalamus.
Okay.
By activating these receptors, semaglutide essentially signals the brain to reduce hunger signals, decrease food cravings, and increase those feelings of fullness after you eat. It basically helps you feel satisfied with smaller amounts of food and maybe feel less preoccupied with thoughts about eating.
So it's directly influencing those powerful hunger signals and how your brain is perceiving food and fullness.
Precisely. And beyond the brain's control center, it also affects the digestive system itself. It works by delaying gastric emptying. It means food stays in your stomach for longer after you eat. This physical effect contributes to that feeling of satiety, that fullness, and might also impact the nutrient absorption signals that get sent back up to the brain.
Ah, okay. So brain and gut working together.
Exactly. And the Gao et al. Source adds a really interesting little nuance here. They suggest semaglutide might be specifically associated with reduced food craving compared to another GLP-1 RA you might have heard of, liraglutide.
Food cravings. That's something many people struggling with weight can definitely relate to. That could be a key part of why it seems so effective for some.
It could well be a significant factor, yeah.
So this mechanism really explains why it's now being studied and used specifically for weight management in people without diabetes. That FDA approval back in 2021 for obesity treatment in this population, which Moiz et al. Mentioned, that was a really big moment, wasn't it?
It absolutely was. It sort of validated the potential of this whole drug class as a significant new tool for chronic weight management, moving beyond its original diabetes indication.
And as we discussed at the top, these analyses we're focusing on are systematic reviews and meta-analyses. Let's just underscore one more time why this methodology gives us such a high level of evidence. Why should you, the listener, trust this kind of study more?
Right. So when you combine the data from multiple, well-designed, randomized controlled trials, which are really the gold standard for evaluating any medical intervention, you dramatically increase the number of people included, the sample size.
More people, more power.
Exactly. And you also increase the diversity of participants and the settings where the studies were done. This statistical power lets researchers detect effects that might be smaller, but are still clinically important. It also gives a much more precise estimate of the true effect size across a wider population than any single trial could.
So it smooths out the bumps or weird results you might get in just one study.
That's a good way to put it. It helps filter out the noise, the random variation, and gets us closer to the underlying truth of how well the treatment works and what its real risks are. It's generally considered the most reliable way to synthesize all the available evidence on a topic.
Okay, that makes sense. Let's look at the specific stacks of studies these two reviews actually analyzed. Moiz et al., published just this year, 2024, had a very specific focus, right?
Yes, Moiz et al. Was quite targeted. They included 4 randomized controlled trials, which altogether had 3,087 participants. And their inclusion criteria were pretty strict.
How so?
The trials had to use the specific dose of 2.4 milligrams of once-weekly subcutaneous semaglutide. That's the dose that's approved and commonly used now for weight management. And importantly, they had to have a follow-up duration of at least 68 weeks.
68 weeks, so over a year. They were really looking at the long-term picture.
Exactly, focusing on that crucial sustained effect, not just short-term loss.
And these 4 trials, they were all part of a big research program called the SNEP trials.
That's right. STEP stands for semaglutide treatment effect in people with obesity. Moiz et al. Specifically included STEP 1, STEP 3, STEP 5, and STEP 8.
And they were clear about why they didn't include other STEP trials.
Yes, which is helpful for understanding the scope. For example, they excluded STEP 2 because those participants had type 2 diabetes, and this review was focused on non-diabetics. STEP 4 didn't have a placebo comparison group for the whole duration. STEP 6 focused specifically on an East Asian population, and STEP Teens was, well, for adolescents.
Okay, so Moiz et al. Really gives us a clean, focused, long-term picture specifically for that 2.4 milligram dose in adults without diabetes.
Precisely.
Got it. Now, the other review, Gao et al., from 2022, seems like it cast a slightly wider net.
It did, yeah. Gao et al. Included 8 studies in their analysis, with a larger total number of participants, 4,567. Their criteria allowed for studies with follow-up times ranging from just 12 weeks up to 68 weeks. So it includes some shorter trials than Moiz did.
And different doses, too.
Yes, they also included trials that used different doses, not just the 2.4 milligrams per week, but also 1.0 milligram per week, and even some studies that used dose escalation regimens where maybe not all participants reached the full 2.4 milligram dose.
Okay, so Gao gives us a broader overview, looking across more studies, different dosages, maybe shorter time frames that were available up to their publication date.
Right. It complements the long-term specific dose focus of Moiz by showing consistency across a wider body of literature.
So one provides that tight, long-term view of the standard dose, and the other confirms the findings across a broader range of studies and doses. Together, they offer a really robust picture then.
I think that's fair to say, yes.
What were the typical participants like in these trials, based on the descriptions in the sources? Who were these studies actually designed to help?
Looking across the trials included in both reviews, the participants were generally adults. The mean ages typically fell somewhere between 46 and 51 years old.
Middle-aged adults, mostly.
Predominantly, yes. And the participant population was largely female, averaging around 76% across the studies.
Which maybe reflects the demographics of people who tend to enroll in weight management studies, or perhaps those more actively seeking help for weight loss.
That's certainly one possibility to consider. In terms of their weight status at the start, all participants began in the overweight or obese categories. The mean BMI, the body mass index, was usually between 37 and 38 kilograms.
And just to remind listeners, a BMI over 30 is classified as obese, so 37-38 is well into the obese range.
Correct. And the Moiz source actually points out that in the studies they analyzed that specifically reported BMI categories, a really striking 94% of participants had a baseline BMI of 30 or higher. So the vast majority were dealing with obesity, not just being overweight.
And these weren't people trying to lose weight for the very first time, were they?
No, that's another critical piece of context. The sources note that the included trials specifically enrolled adults who reported having made at least one previous unsuccessful dietary effort to lose weight.
So these are people who had already tried and found it difficult to achieve sustained weight loss through conventional methods alone.
Exactly. That highlights that these studies involved individuals who were already familiar with the challenge.
What about other health conditions? Were these generally healthy people apart from their weight, or did they have related health issues, comorbidities?
This is a really important part of the picture, actually. The sources provide details on comorbidities, and they show that many participants did have existing health issues often linked to their weight.
Like what, for example?
Moiz et al. Mentions that common comorbidities included things like dyslipidemia, that's high cholesterol, or other unhealthy lipid levels in the blood hypertension, which is high blood pressure, and also conditions like knee osteoarthritis and obstructive sleep apnea.
Okay, all things often associated with excess weight.
Right. And in the trials that reported this data, about a quarter of participants had at least one of these comorbidities. And significantly, 27.4% so. More than a quarter had at least 3 of these conditions.
Wow. So a large chunk of the participants weren't just dealing with obesity. They were already facing health problems where weight loss could have a direct positive impact.
Absolutely.
That makes the potential health benefits of successful weight loss, beyond just the number on the scale, even more relevant for this specific group.
It really does. It frames the potential outcomes of the treatment, not just in terms of pounds or kilograms lost, but in terms of improving overall metabolic health and potentially reducing the burden of these weight-related diseases.
Okay, this is great context. Let's get into the numbers everyone wants to know, the efficacy findings. How much weight do people actually lose on semaglutide in these rigorous studies compared to placebo? And crucially, was it sustained over the long term? Let's start with that long-term data from Moiz et al., focusing on the 2.4 milligram dose over 68 weeks or more.
Okay. Moiz et al. Provides really compelling data on both relative, meaning percentage, and absolute, meaning kilogram, weight change. Let's take the relative body weight change first, compared to placebo.
Okay.
This means the average difference in the percentage of their starting weight that participants lost between the two groups. Here, the weighted mean difference was a substantial negative 12.1%.
Minus 12.1%. Okay, let's unpack that stat simply for the listener. Weighted mean difference here means the average difference in the percentage points of body weight loss between the semaglutide group and the placebo group across all those trials.
Right.
Giving a bit more statistical weight to maybe larger or more precise studies. So on average, participants on semaglutide lost 12.1 percentage points more of their initial body weight than those on placebo.
Exactly.
That sounds like a significant difference, especially when you remember the placebo group was also doing lifestyle interventions, right? Diet and exercise advice?
Correct. They weren't just getting an inactive injection. They were getting the standard lifestyle counseling, too.
Yeah.
And the 95% confidence interval around that negative 12.1% was negative 13.5% to negative 10.7%.
What does that confidence interval tell us?
A tight interval like that, which is entirely below zero, indicates it's a very precise estimate. It confirms this is a robust, statistically significant finding. It's highly unlikely to be due to chance.
Got it. And in terms of absolute weight, how many kilograms or pounds did that translate to on average?
For absolute body weight change, the weighted mean difference was minus 12.3 kilograms compared to placebo.
Minus 12.3 kilos.
And the 95% confidence interval there was minus 13.6 kilograms to minus 11.0 kilograms. Again, very clearly different from zero.
12.3 kilograms. For those of us thinking in pounds, that's roughly 27 pounds. So on average, across these long-term trials, people on semaglutide lost around 27 pounds more than those on placebo plus lifestyle changes.
That's the average difference, yes.
That average alone feels pretty impactful for someone struggling with obesity.
It definitely demonstrates a clear and substantial average effect size over a significant period of time, over 68 weeks.
How did the broader analysis by Gao et al. Compare on this overall weight loss? Did it find similar results?
It did, yes. Gao et al., remember, pooled a wider range of studies, potentially including some shorter ones or different doses. But they found very similar results, which provides strong confirmation.
Okay.
The mean difference they found in relative body weight change was negative 10.09%. The confidence interval was a negative 8.33%. For absolute body weight, the mean difference was negative 10.54 kilograms.
Still over 10 kilos difference.
Right, with a confidence interval of negative 12.08 kilograms to negative 9.00 kilograms.
To maybe slightly less on average than the Moiz analysis, which focused purely on the 2.4 milligram dose over the long term, which kind of makes sense if Gao included shorter studies or lower doses.
Plausibly, yes.
But still a very clear, statistically significant, and definitely clinically meaningful difference compared to placebo. Both meta-analyses are painting a really consistent picture of substantial weight loss here.
They absolutely reinforce each other's findings on the overall efficacy. It's a strong signal.
Now here's where, for me, it gets really interesting, and perhaps most compelling for understanding the impact of this medication for individuals, not just the average. Beyond just the average weight loss, what proportion of participants actually achieve truly significant weight loss milestones? Moiz et al. Provides some really striking numbers for that 2.4 milligram dose at the longest follow-up.
Yes, these relative risk statistics from Moiz et al. Are, I agree, incredibly powerful. Let's break down some key thresholds people often talk about. First, achieving at least 5% weight loss from baseline. This is often considered the minimum level needed to start seeing some health improvements.
Right, that 5% goal.
In the semaglutide groups, 85.8% of participants reached this goal.
Wow, almost 9 out of 10.
Compared to only 34.7%, about a third in the placebo groups. The relative risk, or RR, was 2.37.
Okay, explain relative risk quickly.
Relative risk tells you how much more likely an event, in this case, achieving 5% weight loss is in one group compared to another. So an RR of 2.37 means participants on semaglutide were more than twice as likely, 2.37 times as likely, to achieve this basic goal compared to those on placebo.
More than twice as likely just to hit that first important rung on the ladder. Okay, what about 10% weight loss? That's a level often associated with more noticeable health benefits.
For achieving at least 10% weight loss, a full 70.0%, 7 out of 10 of the semaglutide group hit this milestone.
70% compared to that.
No, just 15.3% on placebo. The relative risk here jumped significantly, 4.27.
4.27. So participants were over 4 times more likely to lose at least 10% of their body weight if they were on semaglutide.
Over 4 times as likely, correct? A massive difference in achieving that goal.
And it keeps going up from there, doesn't it?
It does. For achieving at least 15% weight loss, 52.0% on semaglutide hit this. So over half the participants.
Over half lost 15% or more.
versus placebo.
Versus just 6.8% on placebo. The relative risk is 7.12. Participants were over 7 times more likely to lose at least 15%.
7 times. That's incredible. And then there's the 20% mark. For someone starting with obesity, losing 20% of their body weight could be truly transformative, right? Impacting mobility, quality of life, significantly reducing health risks.
Absolutely. A 20% loss is a major clinical achievement. And for achieving at least 20% weight loss, 33.4% of participants on semaglutide reached this level. So 1 in 3.
1 in 3 lost a fifth of their starting weight compared to placebo, compared to a mere 2.2% on placebo. The relative risk here is a remarkable 15.08.
15? Participants were 15 times more likely to lose 20% or more of their body weight.
15 times, yes.
That, to me, is such a powerful nugget of knowledge that goes way beyond just the average weight loss number. It tells you that for a really significant proportion of people, roughly 1 in 3 in these long-term trials, semaglutide helps them achieve a level of weight loss that is incredibly difficult, almost unheard of, with diet and exercise alone over the long term.
It really does.
Imagine what losing 20% of your body weight could mean for your daily life if you were starting with obesity and maybe had knee pain or shortness of breath.
It signifies a potential for profound clinical change for a considerable number of individuals. It could shift them into much healthier weight categories and potentially even resolve some weight-related complications they were experiencing.
And did Galvala's broader analysis, even though it pooled different studies, show a similar dramatic trend for these milestones? Did it back this up?
Yes, absolutely. Their relative risks were very much in the same ballpark, confirming the pattern across that wider dataset. They found a relative risk of 3.0 for hitting 0.5% loss, 4.85 for 10%, 7.99 for 2.9 for 15%, and 11.61 for 20%.
Still huge numbers.
Definitely. The specific numbers vary slightly, which you'd expect given the different mix of included studies and follow-up times in Gal's analysis. But the core finding is incredibly consistent and robust across both reviews. Semaglutide dramatically increases the likelihood of achieving these clinically significant weight loss thresholds compared to placebo plus lifestyle intervention.
It's not just nudging the needle, it's moving it substantially for many people.
That seemed to be the clear message from the efficacy data.
Okay, so the numbers on the scale and the percentage points lost are clear and impressive. But you mentioned earlier that many participants had comorbidities, other health issues. Did these studies look at how semaglutide impacted other important health markers beyond just weight?
Yes, and this is a really critical aspect of the potential benefit, not just the weight loss itself. Both sources examine changes in various metabolic and cardiovascular risk factors. Let's maybe look at blood pressure first.
Okay. High blood pressure is obviously a major risk factor for heart disease and stroke, and it's incredibly common in people carrying excess weight or with obesity.
Exactly right. So Moiz et al., looking at those long-term 2.4 milligram trials, reported significant decreases in blood pressure compared to the placebo group. Systolic blood pressure, that's the top number when you get a reading, was lower by an average of 4.8 millimeters of mercury. The weighted mean difference was manic for 4.8 millimeter Hg, with a confidence interval of -5.8 to -3.7.
And diastolic, the bottom number.
Diastolic blood pressure was lower by 2.5 millimilli Hg on average. The WMD was -2.5 millimilli Hg with a confidence interval of -3.2 to -1.8, both statistically significant reductions.
And even reductions of that magnitude, around 5 millimilli Hg systolic, 2.5 diastolic, those are considered clinically beneficial, aren't they? They can reduce cardiovascular risk over time.
They absolutely are. Even modest reductions in blood pressure, when sustained, can have significant long-term cardiovascular benefits. And Gao et al.'s broader analysis reinforced these findings. They reported very similar significant reductions. SBP lower by 5.10 millimilli Hg on average, and DBP lower by 2.1 millimilli Hg. The consistency across the two analyses on blood pressure is really strong.
Okay, good to see that consistency. What about inflammation? I think the sources mentioned looking at CRP.
Yes, C-reactive protein, or CRP. Gao et al.'s analysis specifically looked at this and found a significant decrease in CRP levels with semaglutide compared to placebo. The mean difference was -1.09 milligrams per liter, with a confidence interval from -1.50 to -0.69.
And CRP is a marker of systemic inflammation in the body, right? Elevated levels are linked to increased cardiovascular risk.
That's correct. So seeing a reduction here suggests a potential anti-inflammatory effect, which could contribute to the overall health benefits, especially perhaps for individuals who might have existing inflammatory conditions or risks associated with their weight.
Another positive sign beyond weight loss itself.
Precisely. Gao et al. highlights this as a potential contributor to the observed benefits.
And what about lipids? Cholesterol and other fats in the blood. Did semaglutide affect those?
Gao et al. Reported on lipids as well. They found that semaglutide was associated with improvements in several key lipid markers compared to placebo. While they described them carefully as numeric improvements, the data showed reductions in total cholesterol, TC, LDL cholesterol, often called the bad cholesterol,
Right.
VLDL cholesterol, triglycerides, TG, and also free fatty acids, FFA.
So reductions across the board in several types of unhealthy fats circulating in the blood. That's another important piece of the cardiovascular health puzzle, isn't it?
Yes, absolutely. Improvements in these lipid markers are definitely beneficial for cardiovascular health. It is worth noting, though, as Gao et al. Does point out, that HDL cholesterol, the good cholesterol, did not show a significant improvement in their pooled analysis.
Okay, so mostly positive changes, but maybe not a boost in the good cholesterol. Still, the overall pattern for the others sounds favorable.
Yes, the trend was definitely positive for the markers typically associated with higher risk.
So if we try to connect all this to the bigger picture, given that so many participants, as you said, enter these trials already dealing with conditions like hypertension, dyslipidemia, maybe sleep apnea, these documented improvements in blood pressure, CRP, and lipids are incredibly significant, aren't they?
They really are.
It emphasizes that this isn't just about aesthetic weight loss. It's about directly addressing key underlying risk factors for some of the most common and serious diseases we face.
That's exactly right. For someone who walks in with pre-existing high blood pressure or unhealthy cholesterol levels, achieving these improvements, alongside the substantial weight loss, could genuinely reduce their future risk of having a heart attack or a stroke or other cardiovascular events down the line. The benefits really do seem to go far beyond just inches off the waistline.
And this connects to something really important that was mentioned briefly in the Moiz et al. Sourced the preliminary findings from a big trial called SELECT. Can you elaborate on that a bit? What was SELECT looking at?
Yeah, the SELECT trials were a really important study. It's a large, dedicated cardiovascular outcomes trial. It was specifically designed to investigate semaglutide in people who are overweight or obese and have established cardiovascular disease, so they already had heart problems. But, crucially, like the people in our reviews, they did not have diabetes.
Okay, so a high-risk group without diabetes. What did the early findings suggest?
The preliminary findings, which were cited by Moiz et al., suggested that semaglutide treatment led to a significant 20% reduction in major adverse cardiovascular events, often called MACE.
MACE, that includes things like heart attack, stroke.
Exactly. Heart attack, stroke, and cardiovascular death.
Yeah.
Compared to placebo over the trial period, there was a 20% relative risk reduction in those major events for the semaglutide group.
Wow. Okay, so this isn't just about improving the risk markers like blood pressure and lipids. This trial suggests a potential to actually prevent the hard cardiovascular events themselves in this high-risk population. That sounds like a potential game changer.
It's a very strong signal from a major, well-conducted trial, yes. Now, these preliminary findings are distinct from the specific efficacy and safety data for weight loss that came from the meta-analyses we've been focusing on.
Right, different studies.
But they add a really critical layer to understanding the potential broader benefits of semaglutide in this population. They strongly suggest that the drug's positive impact on those cardiovascular risk factors actually translates into meaningful reductions in real clinical events, particularly in people who are already living with cardiovascular disease. It really underscores that treating obesity effectively can have profound positive effects on overall cardiovascular health.
That's a massive potential implication. It kind of elevates semaglutide potentially from just being a weight loss tool to maybe being a cardiovascular risk reduction therapy for this specific population.
That appears to be the direction the evidence is strongly pointing, yes. Although, of course, the full detailed data from SELECT will provide even more nuance when it's published.
Okay, so we have really compelling evidence now of significant, sustained weight loss and positive impacts on key health markers, potentially even reducing actual heart attacks and strokes. But with powerful medications often come potential side effects. Let's turn to the safety profile reported in these meta-analyses. What did they find regarding adverse events overall? Did more people on semaglutide experience any side effect?
Okay, safety. Both sources found that adverse events, or AEs, were actually very common in these trials overall, occurring in around 90% of participants in both the semaglutide and the placebo groups.
90% in both. That's high across the board.
It is, which tells you that participating in a long clinical trial, even with placebo and lifestyle advice, involves reporting things. However, the overall risk of experiencing any adverse event was only slightly higher in the semaglutide group compared to placebo. Moiz et al. Found a relative risk of 1.02, which was not statistically significant in their analysis.
Meaning it could have been chance.
Right, whereas Gao et al., in their broader analysis, found a relative risk of 1.10, which was statistically significant. So the signal is that while AEs were frequent anyway, semaglutide did slightly increase the overall chance of experiencing some kind of adverse event.
But the key is really the type of adverse event, isn't it? What kind of side effects were more specifically and clearly linked to semaglutide itself?
Yes, this is where gastrointestinal or GI adverse events really stand out. They were the most notable difference between the groups by far. Both meta-analyses reported a much higher incidence of GI AEs in the semaglutide groups.
How much higher?
Moiz et al. Found they occurred in 77.2% of semaglutide participants versus 52.2% of placebo participants. That resulted in a relative risk of 1.47.
So about 1.5 times more likely to experience some kind of GI issue.
Correct. And it's interesting, as you noted in the outline, that Gao et al. Reported the exact same percentages and relative risk, 77.2%, Maz's 52.2%, RA 1.47 for GI AEs.
That strong agreement really suggests these numbers are probably drawing from very similar core trial data and are likely very reliable estimates of how common these GI side effects are.
I agree. That consistency is quite telling. And both sources also specify the most common GI side effects that were reported: nausea, constipation, diarrhea, and vomiting. These are the ones people most frequently associate with these medications.
Now, hearing that over 3/4 of people on the drug experience GI side effects, that sounds pretty concerning on its face. But how severe were they typically? Did they tend to cause people to stop taking the medication?
This is a really critical point for clinical interpretation and for anyone considering the medication. Both sources emphasize that the majority of these GI events were transient, meaning they were temporary and tended to improve over time, and they were mostly mild to moderate in severity.
Okay, so not usually severe or long-lasting for most people.
That seems to be the case. Moiz et al. Specifically notes that the majority of these GI events did not require participants to actually discontinue the treatment. Gao et al. Also confirms their transient and mild to moderate nature.
So common, yes, but often not severe enough to be debilitating or make people quit the drug.
And Moiz et al. Add some valuable context here. They point out that these GI events primarily occurred during and shortly after the dose escalation period. That's when participants were gradually increasing their dose week by week up to the target 2.4 milligram maintenance dose.
So it's often worse when you're starting or increasing the dose.
That suggests that as the body adjusts to the medication, these side effects often lessen or even resolve completely for many individuals over time.
However, some people did have to stop the medication because of side effects, right? What were the rates of discontinuation due to adverse events, or DAEs as they're sometimes called?
Yes, discontinuation due to adverse events was definitely more common in the semaglutide group, and this is a key trade-off to be aware of. Moiz et al. Reported that 6.5% of participants on semaglutide discontinued treatment due to any adverse event.
6.5% compared to placebo.
Compared to 3.3% on placebo. That gives a relative risk of 1.94, so people on semaglutide were nearly twice as likely to stop the trial because of some side effect.
And specifically, how many stopped because of those common GI issues we just discussed? Was that the main driver?
It seems it was. Looking specifically at GI-related discontinuations, the difference was even starker, according to Moiz et al. In their analysis, 4.0% in the semaglutide group discontinued due to GI AEs.
4%.
Versus just 2.6% in the placebo group. That's a relative risk of 5.36.
Wow. Over 5 times more likely to stop treatment specifically because they couldn't tolerate the GI side effects.
Exactly. So while most people could manage the GI issues, perhaps with some dietary adjustments or just time, for a significant minority, around 4% in these trials, they were problematic enough to lead them to stop the medication entirely.
That's a key distinction. Common, but usually manageable. However, for some, they are the limiting factor.
Yes. Gao et al. Also reported a higher overall risk of discontinuing due to adverse events. Their RR was 2.29, very similar. They offered a bit of speculation, too, suggesting that maybe semaglutide's longer half-life, it stays in the body longer, could potentially contribute, perhaps making symptom management harder if you have a bad day, or maybe leading to a more pronounced rebound hunger if treatment is temporarily paused for some reason, which might then lead people to just stop permanently. That's more nuanced thought on why discontinuations might happen.
Interesting point. What about serious adverse events, or SAEs? These are the events that are more severe, maybe life-threatening, or require hospitalization. What was the picture there?
Both sources provide data on SAEs as well. Moiz et al. Reported that the incidence of serious adverse events occurring during the treatment period was numerically higher in the semaglutide group, 9.4%, compared to the placebo group, 6.6%.
Numerically higher, okay. But was the difference statistically significant?
In Moiz et al.'s analysis, their calculated relative risk was 1.36, but the 95% confidence interval was wide, 0.51 to 3.6, and crossed 1.0. This means the result was not statistically significant. Based purely on their pooled data, this observed difference could potentially have been due to random chance.
Okay. But Gao et al. Had a slightly different conclusion on the statistical significance of SAEs, did they?
They did, yes. Gao et al. Also found a numerically higher risk of SAEs. Their RR was 1.34, almost identical to Moiz's number. But in their analysis, pooling slightly different studies, this finding was statistically significant. Their 95% confidence interval was 1.0 to 1.65, which is entirely above 1.0.
So one review says the SAE difference might be chance, the other says it's statistically real. How do we interpret that slight difference?
It's a good example of how subtle differences in which studies get included in a meta-analysis, or maybe the statistical models used, can influence the results, particularly when the underlying risk of the event is relatively low to begin with.
Okay.
It basically means the overall evidence points towards a potentially higher risk of experiencing a serious adverse event with semaglutide compared to placebo. But the magnitude and the certainty of that increased risk are slightly different depending on which specific pool of studies you're analyzing. Both analyses show a higher likelihood numerically, though. The clinical implication really requires careful consideration of what types of SAEs were actually occurring, which these reviews didn't detail extensively.
Right, the overall number doesn't tell the whole story. Were there any concerns raised about hypoglycemia or dangerously low blood sugar, especially given this drug class started in diabetes treatment?
That's an important safety point.
Yeah.
Gao et al. Specifically analyzed the incidence of hypoglycemia and, reassuringly, found no statistically significant difference between the semaglutide and placebo groups. Their relative risk was 0.94, essentially showing no difference.
Good. So that's not a significant concern for this use case in people without diabetes.
Exactly. It's expected in a non-diabetic population not taking other glucose-lowering meds, but it's an important safety confirmation.
And sadly, the sources do mention that deaths occurred during these long trials. What did they report?
Yes, unfortunately, deaths do occur in large, long-term trials involving older adults, often with comorbidities. Moiz et al. Reports that across the 4 large trials they included, over 3,000 people followed for more than a year. There were 2 deaths recorded in the semaglutide group and 1 death in the placebo group.
Okay. And what was the conclusion about whether the treatment caused these deaths?
This is crucial. The source states very clearly that the investigators for each individual trial assessed these deaths and concluded that none of them were considered related to the assigned study treatment, whether that was semaglutide or placebo.
And did the reported causes of death seem varied? Did they cluster in a way that might point to a drug effect despite the investigators' conclusions?
They seemed quite varied, yes. The reported causes in the 2 participants in the semaglutide group were sudden cardiac arrest and myocardial infarction, heart attack. The source provides context that these specific participants had significant underlying health issues, including histories of hypertension, obstructive sleep apnea, smoking, and dyslipidemia, all known risk factors for such events.
Okay. And the death in the placebo group?
The cause of death there was reported as glioblastoma, which is a type of brain tumor complicated by aspiration pneumonia and sepsis. The fact that the causes are varied occurred in both groups, and that all these participants had actually discontinued their assigned treatment before the death occurred, all supports the investigators' assessment that these tragic events were not directly caused by the study drug itself.
Okay, that's important context. So if we try to synthesize the whole safety picture then, The most prevalent issue by far is the common GI side effects, nausea, diarrhea, constipation, vomiting. These lead to higher discontinuation rates compared to placebo.
Right, that's the main hurdle.
But for most people, these are reportedly mild to moderate, transient, and often improve, especially after the dose escalation phase.
Right.
Serious adverse events, while numerically higher in the semaglutide groups in both analyses, were statistically significant in one review but not the other. The overall rates were relatively low, and deaths were rare and not deemed treatment-related by the trial investigators. So Gao et al.'s overall conclusion of acceptable safety seems to capture that balance reasonably well.
I think that's a fair summary based on these robust analyses, yes.
Yeah.
The safety profile isn't completely benign. Those GI effects are real and affect many people, but the nature of the most common events appears generally manageable for the majority, and this needs to be weighed against the significant potential benefits we discussed earlier.
Okay, let's try and connect all these dots now and think about the broader implications of everything we've unpacked from these findings. What's the big takeaway message here, synthesizing both the efficacy and the safety data?
I think the primary, really resounding message from these comprehensive analyses is that once-weekly subcutaneous semaglutide at that standard 2.4 milligram dose provides substantial, clinically meaningful, and importantly, sustained weight loss in adults who are overweight or obese and do not have diabetes.
And we're talking about average weight loss in the range of 10–12% compared to placebo, which translates to roughly 22–27 pounds more weight loss on average.
Exactly. But maybe even more importantly than the average is that it significantly increases the chances for individuals to achieve those higher, really impactful weight loss thresholds like 10%, 15%, or even that remarkable 20% loss.
Goals that are notoriously difficult, bordering on impossible for many to reach and maintain with traditional lifestyle interventions alone over the long haul.
Precisely. And Moiz at Way underscores this by noting that conventional methods often prove insufficient for achieving sustained weight loss in the context of obesity. This really reinforces the modern understanding of obesity as a complex chronic disease and suggests that medication can be a vital tool to use alongside lifestyle changes, not instead of them.
Yeah, it's not a marginal effect we're seeing here. It seems to be a significant intervention that helps a large proportion of people achieve weight loss levels that can genuinely impact their health and their quality of life in a big way.
That seems undeniable based on this data.
And the benefits clearly extend beyond just the number on the scale, as we discussed.
Crucially, yes, we saw those consistent improvements in important metabolic and cardiovascular risk factors, lower blood pressure, reduced levels of that inflammation marker, CRP, and improvements in several lipid profiles like LDL cholesterol and triglycerides.
Which is especially relevant for the many individuals in these trials who already had comorbidities like hypertension or dyslipidemia when that started. For them, these improvements directly address their long-term risk of serious health problems like heart attack and stroke.
Absolutely. So the total package really appears to be significant weight loss plus measurable improvements in key health markers. That's the benefit profile identified in these studies.
Okay. And then on the safety side, the main trade-off seems to be those very common GI side effects, nausea, constipation, diarrhea. While they appear to be mostly mild to moderate, transient, and manageable for the majority,
Right.
they do lead to a higher rate of people stopping the treatment compared to placebo. That's the main hurdle.
That is the primary trade-off, clearly identified in the safety data, yes. The benefits are substantial, but they come with a high likelihood of experiencing these specific GI side effects, which really require proactive management, patient counseling, and setting realistic expectations from the start.
The Gao et al. Analysis also had that intriguing point about dose considerations, which raises an interesting question about how to best optimize treatment for individuals.
Yes, that was interesting. Gao et al. Observed, as you might expect, a general dose dependence for efficacy, meaning higher doses, tended to result in greater weight loss overall.
Makes sense.
But then their subgroup analysis, looking at adverse events, produced a somewhat counterintuitive finding. They found that the 2.4 milligram dose, which provides that strong efficacy we've been discussing, surprisingly showed less occurrence of overall adverse events, nausea, and diarrhea compared to the lower 1.0 milligram dose and even some higher experimental doses that were included in some trials they analyzed.
That is counterintuitive. You'd normally expect more side effects with a higher dose, wouldn't you? What does that suggest?
Yeah, it's puzzling at first glance. Gao et al. Notes this contrast between the dose dependence for efficacy, more weight loss at higher doses, and this specific finding on adverse events. They suggest it raises an important question for optimizing therapy. It sort of implies that 2.4 milligram might represent a kind of sweet spot,
Yeah, people.
providing strong efficacy while potentially being better tolerated, on average, than some lower or even slightly higher doses that have been evaluated in different trials.
Yeah.
They conclude that the 2.4 milligram once-weekly dose is the recommended one based on the drug's instructions and this balance of efficacy and tolerability seen across the studies.
So it's a good reminder that finding the optimal dose isn't just about maximizing the desired effect, like weight loss, but also about maximizing the chances that someone can actually stick with the treatment because the side effects are manageable for them.
Exactly. Adherence is absolutely key for managing any chronic condition, including obesity, and tolerability directly impacts adherence over the long term.
And just placing semaglutide in context relative to other weight loss treatments, how does it seem to stack up based on what the sources suggested?
The sources generally suggest that semaglutide appears to achieve more substantial weight reduction compared to many older anti-obesity medications, Gao et al. Also specifically references comparative studies indicating that once-weekly semaglutide resulted in greater weight loss than once-daily liraglutide, which is another GLP-1RA that's also approved for weight management.
Okay, so it seems to represent a step forward in terms of sheer potency for weight loss compared to some of the previous options available.
That seems to be the case based on the available comparative evidence cited.
So putting it all together, the picture emerging from these comprehensive reviews is one of powerful efficacy, leading to significant and sustained weight loss for many.
Yes.
Clear benefits for health markers beyond just the scale, and an acceptable, though certainly not side effect-free, safety profile, which is primarily marked by those common, usually transient GI issues.
That is the clear synthesis emerging from these robust meta-analyses, I believe. They provide strong support for the use of semaglutide as an effective medical therapy for chronic weight management in adults without diabetes when used appropriately.
So bringing it back to you, the listener, what does understanding this deep dive really mean for you? If you're someone who is overweight or has obesity and has maybe struggled with weight loss in the past, this provides a clear, evidence-based picture of what a medication like semaglutide could potentially offer.
Yeah, it highlights the magnitude of weight loss that seems achievable for many people, including the potential to reach those really impactful milestones, 10, 15, even 20% loss, that might feel completely out of reach otherwise.
And it clarifies that the benefits likely extend to improving key health markers, which is crucial information if you happen to have existing conditions like high blood pressure or high cholesterol that are often linked to weight.
And importantly, it also provides realistic expectations about the most common side effects, particularly the GI ones. Understanding the typical experience, that they're often mild to moderate and transient, helps you understand the balance between the benefits and the potential downsides, as reported in these large clinical trials.
Armed with this kind of detailed understanding, hopefully you can have a much more informed conversation with your own healthcare provider about whether this type of medication might be a suitable option for your personal health journey and goals.
Absolutely. It helps shift the discussion from maybe just anecdotal buzz or headlines to the actual evidence-based potential, both the good and the challenging.
So, to leave you with a final thought for further consideration, something to mull over that builds on everything we've discussed today. Given this really striking evidence for significant weight loss, the clear improvements in cardiovascular risk factors, and those promising preliminary findings from the SELECT trial suggesting a potential reduction in actual major adverse cardiovascular events in high-risk individuals, what could the long-term public health impact be if effective treatments like semaglutide become widely accessible and utilized for people living with obesity and related conditions?
That's a huge question. And maybe the flip side of that coin is, how will factors like access barriers, insurance coverage complexities, and the ongoing cost of these treatments ultimately influence who is actually able to realize these potential health benefits in the real world, despite the compelling results shown in these clinical studies?
These feel like really crucial questions for the future of obesity care and cardiovascular disease management, don't they? Definitely something to think about. That's all for this deep dive.